I'm pleased to share with you the results of the Commander-HF trial, which I was privileged to chair as the primary investigator. This started from works we have done in the past in our Clinical Investigative Center at University of Lorraine and in CERM and University Hospital of Nancy. Indeed, we have hypothesized that the worsening heart failure is very much related to thrombin and coagulation. So far, patients with coronary artery disease and worsening heart failure had no indication of antithrombotic therapy, or only when they go into acute coronary syndrome or in atrial fibrillation. So we have addressed this unmet need with very high event rate, worsening heart failure, no atrial fibrillation, but still coronary artery disease, chronic coronary artery disease, with the hypothesis that thrombin is a deleterious factor which may produce worsening heart failure through deterioration of endothelial function, through microthrombi in the microcirculatory artery, and also through promoting inflammation, all of which are important elements in the pathophysiology of worsening heart failure. We have been trying so hard over the last 10 or 15 years with many hypotheses which didn't work out. We have addressed this disease by anti-renin therapy, by vasopressin, anti-endothelin, and many other mechanisms which we thought are operational in this disease. And all didn't work out. And of course, we have thought that maybe we are missing the target, and one of the important targets is thrombin. So we have focused on thrombin, and we have this better tolerated antithrombin therapy, which is rivaroxaban at small dose, 2.5 milligram, twice a day, and we have compared it to placebo in a large-scale trial, 5,000 patients, over 700 sites, international, global, and we have coordinated this over the last 3 or 4 years. The average follow-up time was 21 months. And disappointingly so, the results were not positive. Indeed, the thrombin hypothesis didn't work out. Rivaroxaban did not decrease the rate of the primary outcome, which was all-cause mortality, stroke, and myocardial infarction. So, in a way, although this trial would not change the future of therapy in heart failure with worsening episode, but it has definitely closed the door. We did answer a question. This means that thrombin is not a mechanism which is important to mitigate in the situation of worsening heart failure. There have been trials before with warfarin which were not conclusive, and we still had this question open. Now we have closed this question. Now we are having also additional hypotheses, because as a subgroup analysis of the trial, we have seen that stroke and myocardial infarction and sudden death, so to say the atherothrombotic events, they did benefit from therapy. What didn't benefit from therapy is the very large amount of cardiovascular death and hospitalization which are related specifically to pump failure and heart failure, which turns out not to be thrombotic. So now we are having additional data that we are going to be presenting very soon at the American Heart Association meeting with subgroups from where we may start with new hypotheses and select among these very high-risk population patients more specifically at risk of stroke and myocardial infarction and atherothrombotic event. And this is the way it works, from one hypothesis to another, hopefully advancing the field of therapy in this disease.
Thank you.